Right, so with introductions done, you all know who I am, you know where I work. And I just want to really start with an introduction, an outline of what we're going to cover today. Now, I want this to be a simple, reflective tutorial on the borderline category in the HPV era. And I want us to ask the question and reflect, does a HPV-informed result influence the cytologist's decision? And with all that said, I'm going to bring this back. I'm going to show a little bit of data, but focus on morphology, where we'll consider the pitfalls and when not to report borderline. And I would also like to, the slide dedicated to the role of checkers in cervical screening. And as I say, these views represent my personal views on the subject. And then hopefully at the end, we'll have 10 cases, polling cases, where you'll be asked to just comment and grade the slides that you're seeing. So with that ado, let's just move to the first, as I say, data. Now, this is a snapshot, it's only a snapshot of the reporting rates from Q1 23 to 24, so reasonably up to date, April to June of this year. And I've anonymized the laboratories, but this shows the low grade and the borderline rate nationally. And we can't separate them out. And it's important to note that the borderlines, because of the huge variation in data, they're not used as a quality marker or standard by ASCUS, but it doesn't mean that we cannot look at them internally or indeed, among our provider labs. So there's 2 laboratories which have quite a significant high borderline low-grade reporting rate. All the other laboratories reporting under the 25%, and the national average for England is 30%. So just keep some of those figures in mind, and we move to the next slide, where we're going to start asking some questions. Are the borderline rates high due to overcalling? And again, the second question may in fact answer the first. Are borderline rates high as we continue to find more disease? We know that across the country, population characteristics, and certainly here in London, we see it, variation and a very mobile population coming and going, and also local colposcopy practices, how they can influence data. And also asking the question, is there a reluctance to call HPV samples negative in a primary screening era? I mean, for years before HPV primary screening, everyone on this webinar, screeners, checkers, consultants, screeners and checkers, have signed out hundreds of thousands of negative samples. So I think they're pretty confident in this. And, I think the screening program in the UK is excellent. But I think sometimes we just need to bring ourselves back to, are we calling things borderline? Now, I'm certainly not the first, and I would like to ask these questions, and I'd like to sort of recommend this paper as reading. Relatively recently published, 2022, Mateka, Denton et al. And they basically did similar. They looked at the influence. They looked at, they looked, all the pilot sites contributed to the data in this paper. And in fact, it was a large sample population, 1.3 million, 900,000 tests, where the HPV result was not known to the cytologist beforehand. And I think about 400,000 tests where the HPV was known. So the paper, there was certainly local variations, but some of the key findings from this paper were that there was an increase in referrals associated with informed HPV result in the borderline category, a 35% increase in reporting borderline, and a 15% increase in low-grade dyskaryosis. Now, what is a very important point and one to take away from this presentation is that the PPV for SIN2 did not decline from the data. So this suggests that the borderlines were actually contributing to finding more significant disease. And it also identified that cytologists were in fact able to differentiate between true abnormalities and hormonal change in atrophy. So those are the key findings of the paper. So they do take time out and read it, it's quite useful. Now let's look at some performance data locally. I've already told you that the national average for borderline and low grade is 30.6%. These are our local reporting rates. Borderline rate for cervical screening London, 21%. But I don't want you to focus too much on the figures, 21%, 56%, and 6.3% for negatives. I want you to look at the ranges because this is consultant reporting data. And I think this is what we need to try to, and certainly we're making, efforts, but probably what all laboratories are doing, or indeed should be doing, is just looking at the ranges. 9.5 to 31% is the range. So some people are certainly calling more things borderline than others. Low grade, perhaps not so much variance. But again, the negative reporting rate, and this is something I'm quite interested in, a huge variation, 0.6 calling or downgrading things from borderline or whatever grade to negative, and up to 18%, so huge variation. And really, in all of this performance data analysis and ongoing audit is important to identify trends and intervention where necessary. And that's what we're all about, just getting better and improving. It's only, bear in mind, 3 years since all these laboratories centralized, so it has been a huge task. But educational and multi-header sessions are a valuable tool to rein in reporting drift. And I'd love to hear at the end of this if you've some ideas that we can share and discuss. So moving on, this is just again some local data, and it shows our, I've highlighted the top 2 rows in yellow because I don't really want to go beyond the scope of this, the borderline challenge, the title I've been given. But if we look at the borderline rate, the first 46, nearly 47% have nothing at colposcopy or no CIN. 18% showed HPV changes, and almost 30% showed CIN. So those borderlines did in fact pick up CIN. Well, you can say, oh, well, 40%, 46% showing nothing. But remember, this is a virus, a transient virus. So, things can change, but that is the data at the moment. So as I say, I don't know, you can just sort of compare that and think about the bigger picture. So define borderline. When I actually typed this, I thought, my goodness, this is almost impossible defining borderline. But borderline nuclear changes represent a broad morphological spectrum, and we see these in our work day in, day out. And of course, where there's genuine doubt about the significance of nuclear changes. It's important not to miss dyskaryosis and undercall, but equally important, it's important not to overcall. So that's where the checkers, the pathologists, the checkers obviously having the confidence to sign out negatives, and as I say, to reflect on what shouldn't be called borderline, but also for the pathologists to consider when they're reviewing a slide, to also, they certainly don't see as many negatives as the screeners and the checkers, but equally to have the confidence to knock them back to an R12 recall if they're negative. And just to make the point, borderline is no longer a holding category. All HPV positive borderlines are referred to colposcopy. And as we've seen, 30% of our work reported as borderline, there's proven CIN. But of course, if we're referring things that are not true borderlines, then there's a patient anxiety and an impact on colposcopy resource with increased referrals. And so those are just a few points on defining borderline. Now at the beginning I said I wanted this really to be about morphology, and this list is not exhaustive, but it certainly represents some of my gremlins over the years. Atrophy, metaplastic cells, and GAAs, maybe at the end, because we can have a chat about GAA preparations if we've got time, because I think they can be, if GAAs are not done well, then they can create issues, undercalling, overcalling. Now, I've poached this table from cytopathology, one of the chapters in the latest edition, and I think it's very helpful avoiding the pitfalls. And I would say to everyone, just think about this when you're examining a slide in your day-to-day work and you want to call it borderline. Think about degenerative change, the changes that occur in the nucleus. You can get a nuclear enlargement, vacuolation, condensation of chromatin, all the things that can mimic dyskaryosis. And of course, the cytoplasm, vacuolation, cytolysis, and perinuclear halos. And the same with regenerative change. You can have enlargement, you can have multinucleation. A multinucleated cell doesn't mean it's a borderline as long as the nuclei within it are, showing no signs of, especially the chromatin really. And of course, hyperchromasia. I mean, the minute we think hyperchromasia, we think dyskaryosis, but of course, in regenerative change, because of the increasing DNA, it's naturally going to appear more hyperchromatic. Evenly distributed chromatin. And chromatin really, I think, is the king here in terms of working out whether something is borderline or not. And of course, nucleoli, when we see nucleoli, immediate reaction is it's either reactive or it's cancer. But again, it's thinking just about the whole context of the smear and what you're looking at. And of course, when we see sheets of cells, cytoplasm, that's quite common in repair. And just, so I honestly find this a very useful table. And as I say, I will keep using the term reflective. So I want you all to reflect on these criteria in your day-to-day work. Now, I did say, let's just, this is not the quiz at the end or the cases. So these first two, I don't know if it's just me, but I certainly think in a HPV era, we're seeing more and more atrophic smears, and some of them can look very, busy, very hyperchromatic, and they do take time. And as I say, usually these are the slides I'll get at the very end of the day, and the first thing I do is make a decision when I see a very busy atrophic smear is to put it to one side and do it the following day. But the point I want to make here is, for the screeners, checkers, pathologists, is it's back to the old skill set of looking at the cells, focusing up and down through the nuclei. And I hope that, now I appreciate this is a webinar, these images will never match what you see under the microscope, but that even though this looks busy and crowded, the nuclei are all relatively uniform. And in fact, I would hope you would agree this would be reported as a negative smear, which in fact it was. And I think we have a few navicular cells there in the background. So that's atrophy. Metaplastic cells again, another gremlin. And again, we have a very flat sheet of cells. What can we say? Well spaced out. Very prominent nucleoli. And the question is this something sinister, or indeed is it a case of repair, what we know as repair? And I think the clue here is that this a little bit of variation, but the chromatin is relatively uniform. So as I say, we may have a conversation at the end. The image on the right, again, metaplastic, but a lot more crowded, a lot more, and as I say, this would be one where you probably would be worrying, is there something going on? And again, back to the old skill set of taking your time, focusing up and down through the groups, and in particular, looking out to the edge of the group, because that's sometimes where you'll either reassure yourself it's normal, or indeed confirm that there's something more sinister, and this needs referral to a pathologist. Now, inflammation and degeneration, part and parcel of everyday smears. And the images that I've shown here, now this is a group of cells, loosely cohesive cells with very lacy cytoplasm, nuclear enlargement, and some inflammatory debris on top. And I hope you would agree that this is a negative sample showing degenerative changes, and that it really doesn't warrant borderline. But as I say, maybe at the end we can talk more about that. I have seen, even in our own laboratory, sometimes samples or slides like this dotted and referred through as low-grade dyskaryosis. And I think this is what I mean by reflection. You may all disagree with me, but as I say, I think these are some of the categories that we're maybe overcalling on borderline. The image on the right, again, I think it's a slight sort of chromatin, or coarse chromatin, but nothing. These are, I think, sort of textbook inflammatory changes. A nice little perinuclear halo nuclei the same size. So this would fit within certainly my inflammatory, negative inflammatory category. Now, the reason I've included iatrogenic change is really to make the point about clinical information. We're so reliant on our sample takers giving us accurate and concise information. And you know, if you were to see these cells without seeing the actino, or indeed not being told that the individual has an IUCD, you may start to worry that there is something more sinister. So again, screeners, checkers, pathologists, we always have to be mindful. We have to be vigilant and remind ourselves of what other entities can be present in the samples, rather than just automatically defaulting to borderline. And of course, there's the other entities and that we come across in our day-to-day work. And this is a nice example. I hope you recognize it, but single, dispersed, very even, a little bit of crowding in the center, population of cells. And as I say, the giveaway is really the tingible body macrophage, that this is a cluster of lymphoid cells seen in follicular cervicitis. The issue comes if you don't have a tingible body macrophage, or you just have this population of cells. So it's always about keeping these other entities to the forefront of your mind when you're screening. And as I say, if in doubt, obviously get another opinion. Now the slide on the well, it's my right-hand side of the screen, is it's classic herpes. And obviously you've got the ground glass nuclei and the intranuclear cytoplasmic inclusions. But where the problem comes is if the ground glass, or indeed the intranuclear inclusions, are not that obvious, as can be. You'll start to see changes, maybe not just in these cells, but in squamous cells, and sometimes cells you will call something borderline, when in fact it is in fact herpes. So it's just being mindful of the other entities that we may come across. And of course now HPV primary screening and only 15% reflexing to cytology, we're seeing less and less of these sort of, because they've all really been weeded out in HPV. So if it's a HPV negative sample, but it's still something we have to keep in our minds in our day-to-day job. Okay, so I'm just talk a little bit about this group of cells. Now, it may not be very obvious from the image, but this is a cluster of navicular cells. And again, it's resisting the temptation to want to call this low-grade or indeed coilocytic change. But by focusing up and down through the cells on your microscope, you will see the glycogen, which will help. Not every halo is a coilocytic one. So again, resist the temptation to call it coilocytes and low grade. Do think about, could it be just navicular cells? The image on the right is sort of looks like I suppose a cluster of glandular cells, endometrials, but in fact, on closer examination, these are you can see little histiocytes. And I was always told, what was it, 37 years ago plus, that if you see, never underestimate the ability of a histiocyte to mimic, to lure you into that wanting to call it dyskaryotic. So, and it's not always easy. Sometimes if they're in a cluster, they're easier, but, and sometimes the nucleus is not always eccentric. It can be more central. So you have to just rely on those old basic skill sets just to bring you back to everything that you've learned. And I always, when I'm teaching screeners, medical staff, whatever, I always bring people back, and I use it day to day, is identify this, make yourself identify the cell type. And I think that then keeps you on the right track. Sometimes it's not always possible, but most of the time it is. If you can identify the cell type, you'll start to think about what is normal in terms of the nuclear and the cytoplasmic appearance. And obviously also taking into account that table and the features that I showed you a couple of slides ago. Now, just leaving morphology for a second, I really wanted to have a brief one slide, and this is not to the exclusion of screeners or pathologists, but CBMS is the role of the checker. And as I say, this is my personal view on the subject. I mean, this is, I think, lifted from the BAC. The role of the checker is to sign out negatives referred through by primary screeners as abnormal. And of course, the exceptions are if the screener has called it high grade or borderline in endocervicals, it does need to go through to a consultant. But the way the system should work is the checkers should reduce the number of cases going to consultants. And I know it drives me slightly insane if I get something coming through with, I don't mind occasionally one query borderline, but when I get query borderline or query borderline, it's like, I know that checker doesn't really believe that's borderline, but they're obviously sending it through, and rightly so. Everyone is entitled to send a slide through. But if the checkers, we rely on them to basically sift out the true negatives, repeat in 12 months. There will be occasions when there will be difficult slides and they will have to go through for a consultant discussion. On the other side of the coin, the consultants, when reviewing that slide, need also to reflect and remind themselves of the different features that can appear, and as I say, take time just really, or even discuss the slide with the screener or the checker in this occasion. I think timely feedback to screeners is very important. And sometimes checkers will say to me, oh, well, you know, the consultant might agree or disagree. But I always say, well, look, it's an opinion, you know, feedback to the screener. If there is a difference, this is my opinion. I'm sending it through, or I'm signing it out for these reasons. And, you know, honestly, multi-header and the microscope solves a lot of these issues. I believe the checkers perform an important function by maintaining interpretive skills and sort of retaining the status quo within the department, the laboratory. And of course, they are the developing CBMSs to future-proof the service, as long as cytology is required within cervical screening. So, you know, I know different providers, we all do different things, but again, reflect nationally on the role of the checker and the importance that they are, the screeners and the checkers. But I think the checkers are really the ones who separate out the borderlines and so that the consultants are not being inundated with. But it's important also that checkers feel they can come, and they shouldn't shy away from sending something through, but there is a balance to be struck. And I think that's the point I want to make. Now, I should be moving to my next slide. Now, this is where I need to be guided by the team. Christian, are you going to take over at this point? Because we're now actually at the point where I want you to just, we're starting off with hopefully something straightforward and just to grade the case as you. So if you want to just take a few seconds to, not sure, is the poll, is it covering the cells? Can people view the cells?
Yeah, we can't because the poll's in the way.
Yeah, so how do we do that? Do I move it out of the way or does somebody else?
You can drag it on your screen. I've dragged it to the side.
Well, oops. Mine doesn't want to go anywhere. As long as I can see enough, but I want to make sure that everyone else can see the cells.
I always give a good minute as well, Maggie, so people can sort of, you know, drag it to the side, etc. So. Okay, so does individuals have the ability to drag it to the side? Yes, it's not something I can do.
And they're not relying on me to do it. That's all I need to know.
No, sorry, Maggie. Yeah, indeed.
Yeah,
they do it
themselves.
themselves.
So if you just take a few moments and then make your decision.
I'll allow 10 more seconds here because. What I'll do, Maggie, I'll end the poll and then share the results, if that's okay.
That's perfect, thank you. Fantastic. Okay, so we have the consensus is that this is low-grade dyskaryosis. A few people thought of borderline and a few thought negative. So really this is the classic coilocyte, which using UK terminology, BAC terminology, is low-grade dyskaryosis, and I think we have enough there. We have a dyskaryotic nuclei. And this is what I mean about a well-defined halo, not the type of halo you see in the like of navicular cells or indeed perinuclear haloing. So are we good to move to the next slide?
Please do.
Right, so case 2, 24-year-old. And really what I'd like you to do is to look at the picture, the image, and decide where you would place this.
I'll just launch that poll if you bear with me, Maggie.
Yeah, thank you.
Should be coming up now, and I'll allow a minute for results. I think people got the hang of it now because they're answering very quickly.
Maybe it's all too easy.
Okay, most have participated, so I'll give it 10 more seconds and then I'll share the results. They should be coming up now, Maggie.
Excellent. I was really interested to see this poll because dyskaryosis, again, it's associated with HPV, and obviously there's, this was only one image from the cell or from the slide. But in days of old, and I hope at today's training, we were always told to look into the group, and it's only if the nuclei are abnormal that you call it borderline. And as I say, I'm not here to judge. This in fact was reported as a negative due to the fact that there wasn't much nuclear variation. But I think again, it's another pitfall where you would be tempted, and it's very careful. You must scrutinize those nuclei to make sure that you're not, that you're not undercalling. So that's good. So we'll move now to case number 3. One of my favorite gremlins. I like to ask at the end, GAA preps. I don't know how, some people love them, some people hate them. I think if they're done well, but I'd like you just to form an opinion on the cells, the endocervical cells present in the image.
I'll give 15 more seconds, Maggie.
Thank you.
And the results are available.
Excellent. So we've had the consensus is negative with a few borderline, 1 high grade or 2% high grade dyskaryosis and glandular neoplasia. So the right answer is that these are in fact just elongated endocervical cells. And they do attract your attention, but if you go back to your morphology, and this is what you're actually seeing is not true pseudo stratification. So negative, in fact, is the correct answer, and I'm really glad that the audience, the majority, have agreed with that. Maybe if I hadn't have put GAA prep, it probably would have been a different. But I think GAA, as I say, if the preps are well done, they're great. But we find that sometimes on reviews, if it's not an ideal, it has led to undercalling or indeed overcalling and calling things glandular neoplasia. So just another thing to bear in mind when you're back at your microscope this afternoon. Okay, so next slide, number 4. How are we doing for time? Right. Just have a look and take your time. You have a minute, according to Christian.
I'm starting to get a bit meaner than 45 seconds, Maggie, but yeah, maybe a minute. Okay, 15 more seconds. I'll show the results now, Maggie.
Thank you. So I'm just looking here. We have the glandular neoplasia, 58%, few thought borderline and endocevicals, and a few thought negative, one high grade, but the majority glandular neoplasia. Okay, so the story behind this this case, so this is that it was the slide went out as negative. There was this group and there was another group in the same slide, similar, and it went to MDT because the biopsy, for whatever reason, they took a biopsy and there was CGN present. So obviously on the review, we went back and we found this and another group of cells. There was nothing else. So it was a false negative. But I think the learning from this, and that's why I've included it, even if it had been called a borderline in glandular cell in the cervicals, we would have got her into colposcopy. But this is definitely the sort of cells that screeners, checkers, pathologists, we really need to get our eye into, because on examination, I don't know, I put my hand on my heart, would I have called it borderline and endos? Would I have gone glandular based on the fact there was only two groups? But at the end of the day, there's some lessons to be learned here. You know, there is super crowding of the nuclei. There is feathering at the edge, but everything's very delicate. The nuclei on closer examination is quite, on the chromatin is quite granular. So I obviously, by attending workshops and training schools and but we have so much material going through our labs. But I think these very delicate, very few in number groups, they are hard to detect, but you know, the secret is when you see them, don't make assumptions, go down on high power and focus up and down through. And it's, you know, we're just always on a constant learning curve. So as I say, the consensus was correct. It was in fact so glandular neoplasia, CGN on biopsy. And of course, the fact that she's had third HPV positive, it doesn't necessarily mean that there'll be an abnormality there. But again, it's all the things that you have to take into account when you're screening, checking, reporting a case. Okay, let's move to slide number 5. Okay, so once again, just take your time, look at the cells and come up with what you think.
I'll have 15 more seconds, Maggie.
Thank you.
Just shared the results.
Okay, thank you for that. So consensus reporting negative, with a few 11% thinking borderline and 7% high-grade dyskaryosis. So I don't have the histological outcome on this particular case, but in fact the patient has DNA'd, but this was in fact, I think it was called borderline. and then there was a query about moderate dyskaryosis. But it brings me back to the point I made at the beginning, is thinking about identifying cell type. If you identify the cell type, it sort of starts to bring you back to what other possibilities there are outside of, dyskaryosis. The nuclei are quite, well, they're central nuclei. Their NC ratio, I think there's an element of degeneration here. I don't know this cell whether or not, but query histiocyte, but I think there is an element of degeneration. So as I say, I would agree that this is negative or borderline. I wouldn't criticize anybody for calling it borderline, but I think these are maybe the cases where we're sort of, if we are overcalling, that we could fall into that trap. So make yourself go through the pain of identifying the cell type. Thank you. Moving on to the next slide. Just conscious of time. We need to. So case 6, 38-year-old, and this is her 3rd HPV positive. So.
Has that come up okay, Maggie?
Yeah. Thank you.
For some reason I couldn't see it my end as being launched.
I can't, it's not.
No, bear with me. I'll just go back.
Poll 5 is still open. I don't know if that's making any difference.
Yeah, it's not allowing me to launch a poll here, so not sure what's happened. Bear with me.
Can people use the chat?
Hear me?
It should just say launch, but for some reason in the back end office it isn't. So let me just try again.
If not, maybe we can just, people can make a note of it and we could just bring that into the discussion at the end. Or
Hi, Christian, can you hear me?
I can, Alison, yeah.
Poll 5 is still open.
Okay, right, thank you. Let me just have a look there. That may be what it is. Bear with. Thanks, Alison, for that. I'm going to now bring up poll 6. I think that's what it was. It wasn't showing it was still open my end, so okay. I've now launched that. Thank you, Alison Malkin.
thank you.
We're going to have 15 seconds, Maggie, and then I'll end the poll and share the results. Okay, I'm going to share now.
Okay, thank you. So yeah, I was interested again to see, because this really reflects back in the laboratory. This particular case was called everything from negative to borderline to high-grade dyskaryosis. But I think again, it's quite a reactive picture. I mean, I wouldn't fault anyone for calling it borderline, but I think these groups, I mean, I would expect to see a lot more crowding if it was high-grade dyskaryosis. But as I say, that's good. I'm just conscious of time, so I need to move now to the next slide. Otherwise, we'll have no time at the end. And again, we should very quickly be able to get everyone. I'm being kind today, so.
I'll give a strict 45 seconds.
Absolutely. You can even shave it to 30.
Okay, 5 more seconds and then I'll end this poll and share the results.
Excellent. So yes, so the consensus is 94% negative. And in fact, what we're actually looking at is an image I showed you earlier. And it's just a very nice example of follicular cervicitis, singular dispersed cells, and a beautiful tingible body macrophage turned upside down, just to confuse you. So there we go. Thank you for that. And we can move now to case 8. This is my old friend, gremlin atrophic samples. And there's a reason why I'm showing this, and I'll explain after the poll.
We give 10 more seconds.
Okay, so the majority, 53% negative, 26% borderline endos, and 16% high grade. So the story behind this particular, this is an atrophic sample, and this is one of these dark groups that you can't really see into. This lady it was her 3rd HPV positive. So she was going into colposcopy anyway, regardless of whether we called it negative, borderline, or other. And in fact, she did go to colposcopy and nothing was found. There was no biopsy. So they saw nothing on colposcopy. And I think these smears they're not only a problem for us, but they're a problem, again, women going into colposcopy, and of course colposcopy, not knowing what to do with them. There's no exit strategy as such, and obviously this is something that the national team will be trying to offer guidance on through doing some form of audit. But I think in terms of the morphology, which this webinar is about, it's really looking at the cells at the edge. Throughout the rest of the smear, there was very open groups of atrophic nuclei, which were reassuringly negative. But it's when you get these very dark, dense clusters, again, is it safe to assume that the cells we see around the very edge that we are reassured are negative? Is it safe to assume that that's what's going on in the center? Or indeed, is it better to call, as I say, something like this borderline? But it's important not to, when you can't see something, then you're sort of a bit stuck. But always look to the edge of this. I think if you look out to around the edge of the cells and focus up and down through, you may just get enough information to make the decision one way or other. But atrophy, nothing found at colposcopy. Thank you. Next slide. Oh, sorry, I'm talking. Right, slide number 9. Thank you. Apologies, I don't have the age, and I should have it, but
15 more seconds for this one, Maggie.
thank you. Okay, so 47% negative, borderline in cervicals, high grade glandular. So there was a real spread. Okay, maybe that wasn't very fair, that slide, but the reason again I wanted to include it was just, you know, sometimes when people see nucleoli, they start thinking about, you know, reactive, but again, this is not reactive change, it's not negative. This is from a case of endocervical adenocarcinoma. So it was a cancer audit review. And again, down this end, I think once, I appreciate it's difficult just on an image, but going up and at your microscope, you certainly start to see the variation in the chromatin. And I'm not sure if this is completely typical of, obviously there was lots of, but I just wanted to make the point about nuclei and repair and cells being flat and organized. Here you've got a lot more crowding, and so that, as I say, that was from a case of adenocarcinoma. Moving to number 10. Okay, so this is our last slide. I'm conscious with 5 minutes. So again, a group of cells, which you can just have a look and decide. Mm-hmm. Mm-hmm.
Ten more seconds, Maggie.
Okay. All right, this is interesting. Negative, borderline. Okay, high grade, 32% thought it high grade, and 33% borderline. Okay, so this is, let's go back to cell type. Think about cell type and all that I said about, you know, looking around the edge. This, in fact, was, it was interesting. It was called low grade and then reported out as high grade moderate dyskaryosis. And in fact, I'm pointing to these cells up at the end. So once again, and it's proven situ on biopsy. So just another example of cell type, looking into the group, but looking out around the edges. And I think those little nuclei there, you can start to appreciate variation, size and shape and crowding. So that brings us quickly to the end of our polling. So thank you for participating in that. We may have time for a few questions at the end. So if we can now just go back to the Christian, do you take control or do I come to the last 2 slides of the presentation?
You have control, Maggie, of your slides, I think.
So I just, hold on. I am screen sharing on my phone. Okay, great, thank you. So let's just reflect on everything and think about where we are in terms of the borderline challenge. And, you know, slides will always be difficult, but it's looking at what nationally, regionally, locally we have in place. UK training, including the exam, is well defined and provides a good foundation for any cytologists coming into the profession. It's not just about sitting an exam. We have to maintain our competencies, updates, AQA. So, you know, I think there's a lot of rigor around the quality of cervical screening in England. Educational reviews, again, big learning, you know, we do them here regularly, And the only thing I'll say about cancer audit is, and I know there's lots of professional debate out there, and that's another webinar, is, you know, sometimes when we do the reviews anonymously and we try to be very empathetic, but is that making screeners, checkers, pathologists more nervous? The fact that we're afraid to report things as negative. I hope not. Multi-header sessions, performance monitoring, and individual and laboratory level, and is comparison of data, region and national levels will keep us on the right track. My personal opinion, maintaining the role of the checker. And my final slide, as you leave now to either go back to your microscope, where I think we're all happy, is to just the day job, age and clinical information, note background of the slide, identify cell type, apply your morphological criteria, remember that table I showed you, seek alternative opinions, obviously the right opinions, and perhaps adopt a consensus multi-header reporting session for difficult cases. Apologies, that was very hurried at the end, but please be confident you're doing a good job and go back to you. The country needs good screeners, good checkers, and good pathologists. Thank you.
Hi, Maggie. Thank you very much for a very interesting presentation and some great images. I will open this up to Q&A, but if you can come in through the chat, there's been lots of comments, by the way, which I'll go back to, but I'll just see if there's any questions first. So if I could ask people at the moment, don't use the chat for thank you and well done, but if you could just use the chat for questions at the moment, please. And then we'll open it up for a thank you there. Okay, I have one question here, Maggie. Given the huge variation between labs and reporting profiles, can I imagine how we go forward with developing meaningful standards for APV and PPV? There will be big differences between populations for many years. I suppose that's a comment really rather than a question, but do you have any response to that?
Well, you know, back to, sorry, Alison, I am struggling to hear you slightly, but if I rather than repeat the question, I think that, you know, we are back to what I said at the beginning, you know, we're only 3 years in, well, some of us, not all of us, some of the pilot sites have been, you know, 2-3 rounds, but it is all about, you know, audit and gathering the data and then reflecting on that data. And obviously that will be done at a national level and gathering information from that about the performance, the PPVs, the APVs, and everything else. That I hope that's the right.
Yeah, I think from the comments, I think it definitely seems to be an area that people are seeking guidance on and have maybe an element of like confidence in reporting. There's another comment here with regard to often it's made on single cells or single groups of cells, and that there might be a lack of confidence in that, especially in a, I suppose, in a HPV positive smear. So again, I think it might be something that we can take forward to the BAC and look about maybe some form of workshop. And
I think exactly this webinar will inform other, you know, and from the chat, hopefully we'll gather some things that might be of interest to people, but definitely something to keep going.
Yeah, okay, I have another question here. How do we account for the influence of colposcopy practice on how we approach screening and reporting?
How do we, sorry, it's very echoey, Alison, that's my problem.
Sorry, my
hearing
in a separate room here. I'll just leave my laptop and save any vibration. So how do we account for the influence of colposcopy practice on how we approach screening and reporting?
Well, I am in London, we have 26 colposcopy units, and really it's all about communication, education, and keeping the dialogue, you know, even through you know, I'm sure other regions are the same, you know, if there's an issue, and providing them with data as well. It's a two-way conversation, trying to understand, you know, what they're, and I think also reinforcing the guidance as well, you know, what they should be doing and taking biopsies, not just. So I think it's really about education both ways, communication, and sometimes picking up the phone, but also just sharing audit, you know, at open days and at educational forums, so that everyone is learning from either the successes or learning from, you know, what we haven't done so well.
Yeah, that's great. Just the final C-word comment came in very early, and I think this is in relation to the difference in figures between the different labs. And this is in relation to the fact that some of those labs were not part of the pilot HPV screening, and that obviously some of those labs now had 2 or 3 rounds of HPV screening. So there'd be less disease in their population, which may account for some of those figures.
Yeah, and that's a very important point, that they, you know, the labs with a higher, and as I say, they'll need to look at their own data, but certainly are maybe only in the first round of HPV. So this is the thing. I mean, years ago I referred to Amanda Herbert, but she ate, slept and drank statistics, and I think it's about understanding data, interpreting data, and recognizing that there are variations across the country, you know, and not just you know, oh my God, they've got a high borderline rate. Look behind the scenes and, you know your data, understand your data, interpret it, and challenge it where appropriate. And I think that's.
Yeah, that's fine. I think you've highlighted a lot of the tips to try and kind of avoid some of those pitfalls that you've talked about. So that's great. And another agreement here about active MDT meetings as well. So I think and I think now in the interest of time, because we have just gone over a little bit, I would like to thank you on behalf of the BAC for presenting today. It's great that we've had such interest. I think I counted 156 participants at one time. So that is brilliant. And so yeah, I'd say this recording will be put through link to the website and also our YouTube channel. So thank you very much, and again thanks to everyone for registering for this webinar. Thank you very much.